Hi, today I'll be talking about potassium disorders, which include hypokalemia and hyperkalemia. The normal range of serum potassium is 3.5 to 5 milliequivalents per liter. Hypokalemia is defined as serum potassium less than 3.5 milliequivalents per liter. Hypokalemia can further be classified as mild hypokalemia, where the serum potassium is between 3 to 3.5 milliequivalents per liter. Moderate hypokalemia is 2.5 to 3 milliequivalents per liter, and severe hypokalemia can be less than 2.5 milliequivalents per liter. Low potassium diet is linked to hypertension, and high potassium diet has cardiovascular benefits. World Health Organization recommends 3.5 grams of potassium per day in the general population and less than 3 grams in patients with advanced chronic kidney disease. Symptoms of hypokalemia can be neurological, which include weakness, muscle paralysis, and cardiovascular, which could be cardiac arrhythmias. Hypokalemia is usually caused by decreased intake or increased loss and transcellular shift. The causes of hypokalemia can broadly be classified under inadequate intake, intracellular shift, renal losses, and gastrointestinal losses. Inadequate intake is seen in people with anorexia and due to starvation. Intracellular shift could be from refeeding syndrome, alkalosis, medications such as insulin, and beta agonists such as bronchodilators. Gastrointestinal loss could be from acute diarrhea, chronic diarrhea, bowel preparation for colonoscopy, use of laxatives, and enemas. Some of the medical conditions that can contribute to renal loss of potassium are mineralocorticoid excess, type 1 and type 2 renal tubular acidosis, intrinsic renal transport defect conditions such as Batta syndrome, Gitelman syndrome. Medications that can cause increased renal loss of potassium are thiazide diuretic, loop diuretics, exogenous corticosteroids. If the serum potassium is less than 3.5 milliequivalents per liter, one should evaluate for severe criteria, which includes potassium of less than 2.5 milliequivalents per liter associated with severe neurological symptoms such as respiratory depression, paralysis, and cardiac arrhythmias. If the criteria for severe hypokalemia is present, then one should administer 5 to 10 milliequivalents of intravenous potassium chloride over 15 to 30 minutes while on cardiac monitor. This should be done until the severe criteria has resolved and serum potassium is greater than 3 milliequivalents per liter. If there's no evidence of severe criteria for hypokalemia, then one should investigate for gastrointestinal loss, renal loss, or acute intracellular shift from the history. If there is evidence of gastrointestinal loss contributing to the hypokalemia, one should discontinue the contributing medications, treat the underlying cause, and administer potassium supplement. If it is secondary from renal loss, one should investigate and treat the underlying cause, discontinue diuretics, and administer potassium supplement. If it is from acute intracellular shift, one should treat the underlying cause of it. If there's no evidence of gastrointestinal loss or renal loss or intracellular shift, and if there is associated hypertension, one should evaluate for mineralocorticoid excess with checking serum aldosterone and renin. If there is no evidence of hypertension, additional evaluation with urine sodium, urine potassium, serum magnesium, serum phosphate, and acid-base status. If the serum magnesium is less than 2 milligrams per deciliter, then this could be from hypomagnesemia, and magnesium supplement should be given. If there's no evidence of hypomagnesemia, then if there's evidence of acidosis, which could be type 1 and type 2 renal tubular acidosis. If there's no evidence of acidosis, but there is alkalosis, and if the urine potassium is greater than 15 milliequivalents per liter, one should consider renal tubular defect conditions such as Batta syndrome, Gitelman syndrome. Medications for the treatment of hypokalemia. Potassium chloride is the most effective formulation. It is given orally in the dose of 10 to 40 milliequivalents 2 to 4 times per day. Intravenously, it is given 10 milliequivalents per hour via peripheral line and up to 20 milliequivalents per hour via central line. Expect increase in serum potassium by 0.1 milliequivalents for every 10 milliequivalents of KCl given. Potassium bicarbonate is preferred for patients with metabolic acidosis. It is given in the dose of 40 to 100 milliequivalents per day in 2 to 4 divided doses. Potassium gluconate is given in the dose of 10 to 20 milliequivalents 2 to 4 times per day. It's most commonly found over the counter. Potassium citrate is given in the dose of 10 to 20 milliequivalents 2 to 4 times per day. Potassium phosphate, primarily used for the treatment of hypokalemia and hypophosphatemia, For every 1 millimole of phosphate, there is 1.5 millicoulombs of potassium. Hyperkalemia is defined as serum potassium more than 5 millicoulombs per liter. Mild hyperkalemia is defined as serum potassium between 5.5 to 6 millicoulombs per liter, and severe hyperkalemia is defined as greater than 6.5 millicoulombs per liter. Causes of hyperkalemia are broadly classified under increased intake, impaired excretion, and transcellular shift. Some of the causes of increased intake contributing to hyperkalemia are high potassium diet, enteral feeding, potassium supplement in intravenous fluid, and parenteral nutrition. Medications that can cause hyperkalemia from impaired excretion are angiotensin converting enzyme inhibitor, aldosterone antagonist, angiotensin 2 receptor blocker, digoxin, heparin, antibiotics such as trimethoprim, sulfamethoxazole. Acute renal failure, end-stage renal disease can cause hyperkalemia through impaired excretion. Causes of hyperkalemia from transcellular shift could be secondary to metabolic acidosis, hyperglycemia, tumor lysis syndrome, rhabdomyolysis, pseudohyperkalemia, which is caused by hemolysis during venipuncture, sustained tourniquet application, and transport of the lab sample through the pneumatic tube system. Once we have confirmed that there is hyperkalemia with potassium greater than 5 millicoulombs per liter, one should look for signs and symptoms of severe hyperkalemia, which include serum potassium greater than 6.5 millicoulombs per liter associated with neurological symptoms such as muscle weakness and paralysis, or cardiovascular signs such as arrhythmias noted on the EKG. If there are criteria of severe hyperkalemia with EKG changes, then one should immediately administer intravenous calcium gluconate in the dose of 1 to 2 grams and repeat the dose if EKG changes persist. If there are no electrocardiogram changes, then one should administer 10 units of intravenous insulin and 25 grams of glucose in the form of 50 ml or 50% dextrose. Glucose administration may not be needed if initial glucose is greater than 200 milligrams per deciliter. Nebulized albuterol in a dose of 10 to 20 milligrams should be given. One should check blood glucose every 1 hour up to 3 hours while administering insulin with dextrose. Potassium should be checked again in 2 to 4 hours. Sodium bicarbonate in a dose of 150 millicoulombs in 1 liter of 5% dextrose in water intravenously over 2 hours should be given. If the patient is hypovolemic, consider fluid resuscitation. If the patient is not hypovolemic, one should consider giving diuretics such as intravenous or oral furosemide in a dose of 20 to 40 milligrams or intravenous or oral bumetanide in a dose of 1 milligram. If there are no symptoms or signs of hyperkalemia and if it is not secondary to pseudo-hyperkalemia, one should hold the medications that can contribute to hyperkalemia and then give potassium binders, which include petiromar, which is also called as Veltassa, in a dose of 8.4 grams orally once per day, or sodium polystyrene sulfonate given in a dose of 15 grams orally once per day, or sodium zirconium, which is called as Localma, given as 10 grams orally 3 times per day for 48 hours followed by 10 grams per day. Intravenous calcium gluconate stabilizes the cardiac membrane from the effects of potassium. It has no effect on serum potassium levels. Adverse effects of giving calcium gluconate or calcium chloride include hypercalcemia, cardiac arrhythmia. Insulin drives extracellular potassium into the cells. Insulin with dextrose can decrease the potassium by 1 millicoulomb per liter at 1 hour. The onset of action is 15 minutes and the duration of effect is around 2 hours. There is a synergetic effect if administered with nebulized beta agonist. Adverse effects include hypoglycemia,